Last time we discussed about the neonatal sepsis. Today we are going to discuss a topic that is related with the neonatal sepsis, that is necrotizing enterocolitis. As the name indicates, it's necrotizing enterocolitis. Necrotizing means the death of the tissue. Entero refers to the small intestine, colo refers to the large intestine, and itis is related with the inflammation. So it is the inflammation or death of the both small as well as large intestine. It's an acquired neonatal acute intestinal necrosis of not unknown, we can say it's multiple etiology. There is not a single known etiology for this. There is multiple etiologies. So it is a life-threatening acquired neonatal disorder of the GIT, following a combination of vascular, mucosal, toxic insults to a relatively immature gut. Here you can see the slides. In this slide, there is the inflammation and resulting into the death of the tissue involving both small as well as the large intestine. What are the predisposing factors? Factors may be related with the prematurity, perinatal asphyxia, enteral feeding, hyperosmolar formulas, polycythemia, umbilical artery catheterization due to the different procedures, or rapid increment in feeding volumes. I told you in my previous lectures that whenever we are starting to the feeding to the especially to the preterm, or the baby who is not able to take oral feeding properly, we increase the feeding gradually. So if we will increase feed rapidly, then it may result in the inflammation and necrotizing enterocolitis. So these are the multiple etiologies which are involved in the cause of the necrotizing enterocolitis. The most common site is the distal part of the ileum and the proximal segment of the colon, that is most frequently involved. Distal part of the ileum and proximal segment of the colon, that is called the ileocecal region, is most commonly involved. As I told you, it's multiple etiology that might be related with the involvement of the GIT, pathogens, and feeding, like hypoxia due to the birth asphyxia, may result in release of some sort of inflammatory mediators. And as the newborn, the gut is not properly mature, and there might be contamination of the bacteria, like different types of pathogens, endogenous pathogens. Some people may use probiotics, which may result in inflammation. Our formulas which we use, like hyperosmolar formulas, time of initiation of the feeding. If we have started feeding very early and the gut is not mature to digest the food, that may result in the inflammation. And feeding enhancement, I told you, if you are rapidly increasing the amount of feeding or volume of the feeding, it may result in the inflammation of the gut. So there is both sides. There is ischemic or toxic mucosal damage that may lead to the loss of mucosal integrity, and enteral feeding and rectal proliferation. They ultimately lead to the invasion of the mucosa and submucosa. And ultimately, there is collection of the case in between the layers of the intestine, that is called intramural gas. And ultimately, this will lead to the transmural necrosis and perforation and peritonitis. Here you can see, this is the gross view of the intestine, in which the bowel appears irregularly dilated with hemorrhagic and ischemic areas of the necrosis. And the microscopic view, here you can see the mucosal edema, hemorrhage, and ulceration. So this result in the coagulation necrosis, that is the characteristic histologic feature of the NEC. This is the slide in which you can see the abdominal distension. The major manifestation of this is the abdominal manifestation. The onset usually occurs in the first 2 weeks of life, but it can be as late as 3 months of age in very low birth weight infants. The age of onset is inversely related to the age of gestation. In the baby who is preterm will develop these symptoms late, and the term or those who are having the near to the term delivery but history of asphyxia may develop these symptoms rapidly. The signs are divided into two categories. One is the intestinal sign and other is the systemic signs. All these signs you can find out in the neonatal sepsis, which we discussed previously. In intestinal sign, there might be abdominal distension, abdominal tenderness, feeding intolerances, vomiting, blood in stool. There might be occurred or gross blood in stool, delayed gastric emptying, abdominal mass, or erythema of the abdominal wall. And in systemic signs, you can see the lethargy, apnea, unstable body temperature, acidosis that might be metabolic or respiratory, glucose instability means patient may have hypoglycemia, hyperglycemia, poor perfusion, DIC, and ultimately once there is perforation, there is involvement of the blood and the blood culture will be positive. This is the one of the clinical staging criteria in which major type of treatment can be decided. In a stage that is called the Bell's staging criteria. And stage 1 is the suspected NEC, stage 2 is definitive NEC, and stage 3 is the advanced NEC. In stage 1, there might be mild abdominal distension with poor feeding and vomiting. And on X-ray, you will see mild ileus, that is the distension of the bowel loop on X-ray. And on treatment, there will be medical workup for the sepsis, because all these signs you can also see in the sepsis. In the stage 2, there is all of the above signs like abdominal distension, poor feeding, vomiting, along with there will be marked abdominal distension and GI bleeding. In stage 1, there is no bleeding. On stage 2, you will notice the bleeding. And in X-ray, there will be significant ileus. And there will be pneumatosis intestinalis, that I told you that there is collection of gas in between the layers of the intestine. And there will be portal vein gas as well. And this is also treated as on the medical grounds. There is no need of surgical treatment or surgical intervention. And in advanced NEC, there will be all of the above signs which we discussed, along with the instability of the vital signs. And there will be signs of the septic shock. And there is pneumoperitoneum, means collection of the gas in peritoneum, and it's a sign of perforation and peritonitis. Here the treatment is only surgical. There will be no benefit of the medical treatment. How you will diagnose the patients of NEC? It's almost clinical diagnosis, that is the serial physical examinations, lab testing, and abdominal X-rays. There is no any specific test that should be confirm the diagnosis of NEC, because both of these NEC and sepsis, they share the clinical picture. The most common triad which we notice in the NEC, that is feeding intolerance, abdominal distension, and the gross blood in the stool. There is acute change in the stool character. On the supportive grounds, you can go for the CBC, that is there will be raised or decreased neutrophil count. As I told you in my previous sepsis lecture, that you will go for the absolute neutrophil count, in which there will be neutropenia or neutrophilia, and there will be thrombocytopenia as well. Here you can see the radiological findings, in which there is dilated, thickened bowel loops. There is pneumatosis intestinalis, in which you can see the thin layer of gas in between two layers of the intestine. That is called the pneumatosis intestinalis. That is air in between the wall and the wall of the bowel loops. It's a pathognomic finding or diagnostic for the pneumatosis intestinalis. And ultimately, once the patient develops the perforation, there you will see the free abdominal air and the portal vein air. That is a sign of perforation. Here you can see the free air and gas under the diaphragm. So this is the stage 3 findings. So you can also go for the blood culture to rule out the sepsis for aerobes and anaerobes, stool screening for blood, ABGs, serum electrolytes, coagulation profile. The treatment depends, I told you, on the stage of the involvement. In stage 1 and stage 2, there is general management and medical treatment. And in stage 3, you will go for the surgical intervention. And general treatment, you will go keep the patient NPO. You may, if the patient needs to be keep to be NPO for a long period of time, you will go for the total parenteral nutrition. And we will decompress the GIT by nasogastric decompression. We will also go for the start of the IV fluids. As I told you, patient will be NPO, so needs some sort of fluids. There will be strict input-output monitoring, close monitoring of the vital signs and abdominal growth to see the extent or distension. There will be, if there is umbilical artery catheterization, we will remove that. And if there is patient develops the apnea, we will go for the mechanical ventilation. Specific on the, if you are suspecting sepsis, you will start the systemic antibiotics like ampicillin, gentamicin, cefotaxime, along with metronidazole or clindamycin if there is peritonitis or perforation. And surgical treatment on the stage, surgical treatment is for stage 3, not for the stage 1 and 2. And there will be, if there is involvement of the any sign of perforation or peritonitis, you will go for the surgical consultation. And what are the indications in which there is perforation in about 20 to 30% of the cases. And if there is full thickness necrosis and deterioration of the clinical status of the patient despite of the aggressive medical treatment. There is exploratory laparotomy and peritoneal lavage. They are the surgical approaches for the patient who are not treated medically or those who have complications like peritonitis and perforation. What is the prognosis and outcome? NEC with perforation has a very high mortality, that is from 20 to 40%. And the recurrent NEC is one of the rare complications of NEC that occurs in about 5% of the cases. And there is, as there is full thickness necrosis, so there are the chances of subacute or intermittent symptoms of obstruction. As there is resection of the bowel because of the involvement of large areas of the small and large gut, so there will be shortcut syndrome in which the baby will be failure to thrive with a very high mortality. And surgical NEC is the risk for significant growth delay and adverse neurodevelopmental outcome as well, because here not only the baby is preterm, but has the symptoms related with the birth asphyxia as well. How we can prevent it? By proper use of the mother milk, use of feeding protocol with initiation of the feeding trophic feeders, little bit role of use of the probiotics, prebiotics, but they are under study yet. And the avoidance of the prolonged use of systemic antibiotics or empiric use of the antibiotics. Here is the summarized slide in which you can see all the symptoms and the course of the disease. So thank you very much. This is almost, we have finished the neonatology. Inshallah, next week we will be here together to discuss other topics. Thank you very much. If there is any question, you can ask. Any questions, student? You can unmute, and if there is any question, you can ask. Any questions?
No, sir.
Okay. Thank you so much. So
सर
inshallah. जी डॉक्टर साहब.
सर आपने कहा था कि ये जो एडवांसमेंट जो फीडिंग जो है वो फर्दर इस कंडीशन को वर्स करेगी, तो सर हम टोटल पैरेंटल न्यूट्रिशन भी तो देंगे, वो भी स्मॉल जीआई में, स्मॉल इंटेस्टाइन में और लार्ज इंटेस्टाइन में आएगी, तो वो इस कंडीशन को फर्दर वर्स नहीं करेगी?
No, total parental nutrition is given by the parental route. It's not by the enteral route. It's by the parental route. So it will not go into the GIT. We use total parental nutrition by the intravenous routes, not by the GIT. That is, as the name indicates, is total parental nutrition, not enteral. Okay. Hello. Anything else?
No.
Thank you. Thank you, Doctor.